Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, the Junge Deutsche Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes Professor Brett Spellberg in Los Angeles, California, USA, and Professor Norma Jung in Cologne, Germany, with whom we would like to discuss modern antibiotic treatment strategies, focusing tonight on the question in how far oral antibiotic therapies may replace intravenous antibiotic treatment in today's clinical practice. Dear Dr. Spellberg, dear Dr. Jung, it's an honor and a pleasure for us to host you at our academic YouTube channel.
Dr. Spellberg is Chief Medical Officer at the Los Angeles General Medical Center, one of the largest public hospitals in the US. His laboratory research focuses on the immunology, vaccinology, and host defense against highly resistant bacterial and fungal infections. Dr. Spellberg has worked extensively to attempt to bring attention to the problems of increasing drug resistance and decreasing new antibiotics. Dr. Jung is graduate chemist and specialist in internal medicine, infectious diseases, hematology, and oncology, with additional qualification in palliative medicine at the University of Cologne, Germany. She is board member of the Deutsche Gesellschaft für Infectiology and founding member of the Choosing Wisely initiative of the DGIM.
Thank you so much for the invitation to be with you today to talk about my favorite subject. The question we are asking is, are oral antibiotics safe and effective for 3 diseases that historically the medical community has said, don't even think about it. It's malpractice to even think about it. Osteomyelitis, bacteremia, and endocarditis. There are pro and con arguments to be had around oral therapy. There are 3 principal pro arguments in favor of oral therapy for these 3 diseases. First, in contrast to older historical antibiotics, and I'll show you some of these data, modern oral antibiotics absolutely do achieve adequate concentrations in blood and bone to kill bacteria. It turns out the bacteria don't actually know the route of administration you used to give the antibiotics to the patient. They only know if enough antibiotics get to where they are to kill them. It's not like there's bacteria sitting in bone somewhere saying to themselves, well, normally if there was this much antibiotic around, I'd die, but you gave the antibiotics orally, so I refuse to die. Those little bugs, they're smart, but they're not that smart. Second, we know for sure from numerous studies, including multiple randomized controlled trials, that giving the antibiotics intravenously is intrinsically less safe. It turns out hominids did not evolve with large plastic tubing in our central veins for 6 weeks at a time. So we tend to underestimate the rate of harm from this practice. We're talking about things like DVT, deep vein thromboses, central line infections, line fracture and migration, which may require surgery to retrieve, central venous stenosis, bleeding at the site. These are complications that cause both short-term morbidity and mortality and longer-term morbidity and mortality. You get a DVT from a line, you're going to need to be on anticoagulation for months to years. You could receive harm from that years after the initial infection resolved. And in prospective randomized controlled trials, the cumulative rate of these kinds of harm events has been anywhere between 10 and up to 25% of patients. Finally, third, there are now extensive randomized controlled trial data, which we will go through, demonstrating that oral therapy is as effective as IV therapy for these 3 diseases. And there has never been a single controlled study of any kind ever published showing that IV is superior to oral for any of these 3 diseases. So collectively, this feels like a pretty powerful set of pro arguments in favor of oral therapy. They are contradicted by two principal contrary arguments. And this is how these two contrary arguments go. And believe me, 20 years of arguing about this, I have heard this over and over again. These are the principal contrary arguments. First, any data you show me indicating that oral therapy works has imperfections and flaws and has not been proven to extrapolate to every resistance mechanism in every strain of every species of bacteria, causing every body site of infection in every patient in every country and every continent in every planet in our solar system in every solar system in our galaxy in every galaxy in our universe. And second, if you can't show me perfect data with no flaws that has been proven to extrapolate to every resistance mechanism in every species and strain of bacteria causing every body site of infection, every patient, every country, every continent, planet, solar system, in the galaxy, in the universe, then we have to keep doing what we've always done. Those really are the two principal contrary arguments against oral therapy. And here's the problem. As we will see, there was never any data that demonstrated that IV was superior to oral. So what we have is a historical practice based on habit, not data. It does not require perfect data to overturn historical practice based on no data. Any reasonable data can overturn historical practice based on no data. Evidence-based medicine is preferred to eminence-based medicine. As my mentor taught me, he was chair of medicine when I was a student, resident, and fellow, data beat no data, and better data beat worse data. It's actually pretty simple when you distill it like this. Dr. Brass always did have a way with words. If you want to hear it from another luminary of medicine, Dr. Osler is alleged to have told a graduating class of medical students, half of everything you've learned is wrong. The only problem is no one knows which half. Dr. Osler understood that he didn't have all the answers, and he wanted his students to go out into the world and evolve their practice as new things were learned. So, I'm going to show you data from 24 concordant randomized controlled trials showing that oral therapy works. And if your response to those trials is to say, well, those trials have flaws, then I'm going to have to presume that you're aware of some trials that I'm not aware of that have no flaws and draw the contrary conclusion. Because if you're not aware of those contrary trials, well, there's a lot of words that one could use to describe the phenomenon of criticizing 24 concordant randomized controlled trials when you have none to support the opposing position. And with that as an introduction, let us now begin to consider the three diseases in question, and we will start with osteomyelitis. So if you look at the references in national guidelines, societal guidelines, and you trace those references back in time, you will find that the reason we all think you need to give IV therapy for osteomyelitis starts with this quotation in this publication from 1970. This is why, this is the origin of this belief. Dr. Waldvogel and his colleagues said that osteomyelitis isn't really going to be well controlled without IV antibiotics for 4 to 6 weeks. Now, this creates a precedence that's going to come up again later in the talk, because it turns out if you want to create a myth in medicine in which everyone believes with religious fervor to the point of violence if you contradict it, all you really need to do is publish an opinion in the New England Journal of Medicine, and that'll happen, okay? So this quote that established this more than half century of dogma was in the discussion section of an uncontrolled case series of patients treated with IV penicillin and aminoglycosides in the 1950s and 60s. So when I show you the randomized controlled trials, and you're like, well, those trials have flaws, this is what you're hitting me back with. an uncontrolled case series of patients with antibiotics that no one has used in decades is what the evidence that you're hitting. Okay, that seems like a problem for the IV folks. Okay. They didn't use oral therapy in this study because they didn't have oral therapy to use. So, as you can tell, I get frustrated. I have a lot of frustrations. Tend to get frustrated. So a few years ago, a colleague and I decided to do a systematic review of the literature on osteomyelitis. And one of the questions we asked was, if you give antibiotics orally, can you deliver them into bone at concentrations adequate to kill bacteria? And it turns out there are literally dozens of published studies that have asked this question. The way these studies were done is they found patients who were going to undergo a bone biopsy or an amputation. And they gave those patients various oral antibiotics at various times before the procedures. Post-procedure, they took the bone, they ground it up, and they measured the antibiotic in it. And it turns out the fluoroquinolones, metronidazole, linezolid, Bactrim, clindamycin, rifampin, they all achieve adequate concentrations in bone to exceed the target MICs of relevant pathogens. So just based on the pharmacology, we can hypothesize that it should be possible to treat gram-negative, gram-positive, and anaerobic osteomyelitis with oral antibiotics. So the question then is, are there clinical data that validate this pharmacological hypothesis? Yes, there are a lot of them. In 20 years of looking at this literature, I have found more than 40 published observational studies showing that modern oral antibiotics achieve very similar outcomes in osteomyelitis therapy as IV therapy does. And I've never found a single study that claimed the opposite. None of these 40 studies shows that oral therapy bombed, didn't work. They all show similar cure rates to IV. So the IV skeptics are like, this guy thing, observational data. Don't you have any randomized controlled trials you could show me? And I'm like, first of all, y'all's got one historical case series that doesn't even have a control group. So maybe don't be complaining about my 40 observational studies. But okay, if you want randomized controlled trials, I have 11 of them. 11. And you know what the scorecard is of those 11 trials? It's 11-0 in favor of oral. Not one of these trials showed that IV therapy was superior to oral. So are you like now, you're like, 11 trials. If you had 13, I'd believe you, but 11, no, that's not enough. Except the thing is that I know that if I gave you 13, you'd say you needed 15. And if I gave you 15, you'd say you needed 17, because this is no longer about the data. The data are frankly overwhelming. We are now at the stage of psychology. How do we actually convince people to evolve their practice in the face of overwhelming data? So I don't have time to go through all 11 of these trials in detail. We'll just go through 2 of them in some detail and then show you the aggregated results. Now, I started using oral therapy for osteomyelitis in 2006, at which time there were 5 published randomized controlled trials comparing oral to IV, the oldest of which dated back to 1987. So when I started doing it, it was already a 20-year-old idea. It wasn't even new at that point. But everyone I worked with at the hospital I worked with at that time told me that I was A, an idiot, and B, committing malpractice. And I was like, but I have randomized, and they're like, you're an idiot. You're malpractice. They don't want to hear it. I'm like, what? I don't understand. So the same people, 13 years later, when Oviva was published, came up to me and like, all right, well, I guess we finally have a study that shows maybe oral therapy works. And I was like, well, you mean we finally have the 8th study? Because this was the 8th trial that showed that oral therapy works. Now, it was by far the largest, and therefore it is the most important. But it was the 8th, and there have been 3 more since it. 1,000 patients, multi-centered, many different types of osteomyelitis, many different organisms, and many different antimicrobial regimens used. In the primary outcome and the prioritized secondary outcomes, not only was oral therapy not worse than IV, but the point estimate and the majority of the confidence interval actually favored oral therapy. So skeptical was the journal of these results. This was the journal that created the IV-only mythology a half century earlier, after all, that in order to get this paper published, the authors were forced by the editors on resubmission to conduct a non-pre-planned post hoc worst case sensitivity analysis in which they set all the missing data in the oral arm to failure and all the missing data in the IV arm to success. And even that worst case sensitivity analysis failed to establish the superiority of IV therapy. But you know what was different between oral and IV? The rate of adverse events related to the catheter, which was 9-fold higher in the IV arm than the oral arm, about which my comment is, duh. And you know what else was different between the two arms? The investigators administered patient satisfaction surveys to all randomized patients. Patients randomized to oral therapy reported statistically significantly better mobility, self-care, activity, pain, discomfort, anxiety, and depression. It turns out patients don't like having large plastic tubing in their central veins for 6 weeks at a time, again, about which my comment is duh. And of course, oral therapy was less expensive. Now, the most recent, the 11th of these trials, just came out maybe 4 or 5 months ago. This is the COPAT trial, that's what it's called, COPAT. And it was conducted by investigators at the West Virginia University Health System in the United States. And I've actually talked to these investigators about this study. This was a, quote, pragmatic randomized controlled trial. They had no funding to do this trial. It turns out they were having a hard time convincing their doctors to give oral therapy. But when they talked to their doctors, they said, look, if we get informed consent, we're willing to randomize. So this was an effort to get people some experience at giving oral therapy by doing they just started randomizing their own patients because they wanted to convince their doctors that oral therapy wasn't crazy. The way that they selected patients, anybody that the infectious disease service said this is patient's going to need more than 2 weeks of antibiotics was eligible. That was the criteria. If you needed more than 2 weeks of antibiotics, you were eligible. They would approach you and they would see if they could get informed consent. Patients were randomized 2-to-1 oral to IV. And because the eligibility was once IV said you needed 2 weeks, that decision was made quickly. Patients that were randomized to oral therapy only got 4 days of IV therapy on average before they were switched to oral. Very little IV lead-in before oral switch. Now, this is a really important point. 80% of the patients that were approached to participate in the trial refused to give informed consent almost entirely because they didn't want to be randomized to IV therapy. They were like, wait, so you're saying I could do either oral or IV? Well, give me oral. This is a myth that's really important to contradict because I often hear physicians say, no, the patients insist on IV therapy because it's more powerful. No. You told them it was more powerful. So naturally they were like, well, if it's more powerful, I guess I want that. No, if you approach this with equipoise, just as we saw in the Oviva trial, patients do not want a catheter in their body for 6 weeks. They would much rather get oral therapy. Staph aureus was the #1 pathogen causing infections, and there was plenty of MRSA. Now, if you think about which patients required 2 weeks of antibiotics, guess which patients they enrolled? Osteomyelitis, endocarditis, and bacteremia. No kidding. That's who requires more than 2 weeks of therapy. The same 3 diseases we're interested in today are the exact patients they randomized in this trial. There was only 1 treatment failure, so there was no significant difference in efficacy between the 2 arms. However, a quarter of the patients in the IV group had a line-related adverse effect. So the Data Safety Monitoring Board stopped the trial early due to excess harm in the IV arm. And the other thing I like about this trial, aside from just giving us proportions, percentages of harm, they actually gave us a Kaplan-Meier curve of time to harm, which is really striking. So if this patient was your child, your sibling, your parents, your spouse, or you, which arm would you rather be in? Most of this talk is me cracking jokes and trying to be funny. This is the one moment of actual seriousness that I want to just highlight. This idea that it's okay to insist on IV because it's my preference and I've been doing it for 20 years, you're hurting people. You're actively causing harm to people, and that is not okay. So, frustrations, I'm frustrated, a lot of frustrations. Another systematic review of the literature. At the time this was published, there were 9 trials comparing oral to IV for osteomyelitis. There have been 2 more since, so I'm updating the data. Here's your summary table. Here's your 11 trials. Treatment success rate oral, treatment success rate IV, weighted average oral, weighted average IV. And here is your formal random effects meta-analysis forest plot with your summary statistic very clearly showing no difference in efficacy between oral and IV, and your funnel plot showing no evidence of publication bias. Now, if the pharmacology, the 40 observational studies, and the 11 randomized controlled trials comparing oral to IV are not enough, believe it or not, there are 19 other trials, completely separate, 19 other trials. 18 of them are randomized controlled trials. 1 is a quasi-experimental pre-post trial. 9 were done in adults, 10 were done in children, in which almost all the therapy in both arms was oral. So here we're not comparing oral to IV, we're comparing oral to oral, either because we're comparing different durations of therapy or we're comparing different oral regimens. And amongst these 19 other studies, every single conceivable manifestation of osteomyelitis has been studied. Vertebral osteomyelitis, diabetic foot osteomyelitis, prosthetic joint osteomyelitis, and in every single one of these trials, the cure rates in both arms were the same 75% plus or minus 10% we always see from IV therapy for osteomyelitis. So the data here are simply overwhelming. This is a settled scientific question. There is no contrary data. There is no evidence of IV superiority. And the data that oral is safe and effective for osteomyelitis is overwhelming. The only question that remains is how do we convince doctors to evolve their practice? That's osteomyelitis. What about bacteremia and endocarditis? I showed you the study from 1970, the uncontrolled case series that led to the myth of IV-only therapy for osteo. What's the similar history for endocarditis? You have to go back a little further in time. People sometimes forget that before penicillin came along, oral sulfa drugs were really the first miracle cures in medicine. Sulfa became available in Europe in 1933 and in the United States in 1936. And in 1943, this physician decided to look at the outcomes of sulfa for endocarditis. Sulfa worked really well for many types of infections, not so much for endocarditis. So he compared 764 patients with endocarditis treated with sulfa to 2,500 patients from the pre-sulfa era. And what he found was that before sulfa drugs became available, endocarditis was almost uniformly fatal. The survival rate was well under 1%. Now, sulfa did a little bit better. It got you to 4% survival. You could sort of mathematically summarize that difference as 400% of a not very good outcome is 400% of a not very good outcome. Nobody was impressed by this. Such that when erythromycin and tetracycline came along orally in the late 40s and early 1950s, they were also attempted. And they did a little bit better, They got you to a 20% treatment success rate from endocarditis, but that was nowhere near what IV penicillin was achieving in the 75 to 80% rate. And that's it. These historical case series from the 1940s and 50s with 3 antibiotics that no one has used to treat a patient for 30 years was the sum total data available when, in 1954, one of the giants of internal medicine from Harvard University published a 2-part review article on endocarditis therapy in, guess which journal? The New England Journal of Medicine, in which he said, and I quote, "Oral may sometimes work, but it probably usually doesn't, although we don't really know because there's not a lot of data." This is it, folks. If you look at the national guidelines and you trace their references back in time, the origin of the IV-only myth from endocarditis is this opinion based on oral sulfa, tetracycline, and erythro case series from the 1940s and 50s. So when I show you the randomized controlled trials, you're like, well, those trials have flaws. This is what you're hitting me back with. More frustrations, a lot of frustrations, as you could tell. So another systematic review of the literature, again, starting with pharmacology. Tetracycline and erythromycin are very interesting drugs. They have massive volumes of distribution. When you give them, whether you give them orally or IV, it doesn't matter. They very rapidly leave the bloodstream, and they are heavily concentrated intracellularly in organs. So even if you give them IV, you cannot achieve high peak blood levels from these 2 drugs. The blood levels from these drugs are very low. You can't get above the MIC of target pathogens. Now, sulfa's blood levels were better, but this is not trimethoprim sulfa. This is sulfa by itself. Its MICs were incredibly high. This is a very weak antimicrobial agent. You cannot reliably get sulfa levels in blood above the MIC of target pathogens. So here's the question. Why would you think that 3 drugs that achieve very low levels in blood relative to those needed to kill bacteria would be effective to treat high-grade bloodstream infections? That makes no sense. In contrast, modern oral antibiotics absolutely achieve levels in blood that are far in excess of those needed to kill target bacteria. So we can once again hypothesize it should be possible to treat bloodstream infections with modern oral antibiotics. Are there clinical data that validate this pharmacological hypothesis? For bacteremia, we summarized 13 observational studies comparing oral to IV antibiotics. And this is nearly 5,000 patients, which show that oral therapy works across these studies. And so then people are like, yeah, but there's not enough Staph aureus in there. So that there's 1,000 patients. Stop making excuses. Stop pretending there's little reasons why your patient. No. There's not enough MRSA. There's 600 MRSA patients in these 13 studies. People, stop making excuses and pretending that you don't have to evolve because the data are somehow flawed. Here's a tabular summary of these 13 trials. You can see the gram-negative studies, the gram-positive studies, a tremendous amount of staff in these studies. So you're like, yeah, but those are all observational. Don't you have any randomized controlled trials? And I'm like, well, I have 12. I have 12. And the scorecard is 12-0 in favor of oral. Now, the most recent trial is the COPAT trial I already talked about for osteo, which included both gram-positive and gram-negatives. So there are 8 trials that study gram-positive bacteremia and 5 that study gram-negative bacteremia. In not a single one of these trials was IV superior. However, in several of the trials in which linezolid was compared to glycopeptides, linezolid orally was superior to the glycopeptides. So here's your 12 studies. Here's your 12 randomized controlled trials. Treatment success oral, treatment success IV, weighted average oral, weighted average IV. And here is your random effects meta-analysis forest plot. Now, I can't quite conclude statistical superiority of oral therapy because it does barely cross the 0 line. You can see the confidence interval here. But boy, the data sure skews in favor of oral. The one thing I can tell you is that it's not less effective than IV. We're very confident of that. And that was the question we set out to ask in the first place. So that's bacteremia. What about endocarditis? We have 15 case series of modern oral antibiotics to treat endocarditis, most of which was left-sided disease, and there were a number of prosthetic valves in there, many different organisms, including MRSA, and in every single one, oral therapy worked fine. There was none of these 15 studies like, oh my God, oral therapy failed. No, it looked fine. There are also 6 slightly more rigorous, controlled observational studies, and I'm actually going to go through these 6 just because endocarditis is the most controversial. So it's worth really seeing the data. So we'll quickly go through these 6 controlled observational studies. The first one from 2011, 66 patients with endocarditis, mostly left-sided, a lot of staff. 19 patients were switched to oral therapy, and 47 were not. Now, the patients switched to oral therapy were not switched to oral therapy because they were doing well. They were switched to oral therapy because they developed a complication from the IV and had to be given oral therapy. None of those patients died, while a quarter of the patients getting IV therapy died. Now, it's observational. You can't draw causality conclusions here, but it certainly suggests that you can select patients who can be safely given oral therapy for endocarditis. The second study is much larger, 200 oral, 200 IV. Again, mostly left-sided, lots of prosthetic valves and devices, fair amount of staff, many different antimicrobial regimens, statistically significantly less death in patients who got oral than IV therapy. Third study was our study from the public hospital system of Los Angeles in California. Staph aureus was the most common cause, and there was significantly more MRSA in the oral arm than the IV arm. And yet, despite having more MRSA, which you would have predicted they would have done worse, there was no difference in survival, clinical cure, or relapse in patients treated orally or IV. There was, however, a massive reduction in adverse events when patients were treated orally. Now, we also looked for the patients that were treated orally. Did they do better if they got longer duration of intravenous therapy before switching to oral? And the answer is no. There was no relationship between the amount of IV therapy given before oral switch and how the patients did. The fourth study is this large study from Denmark, which was post-POET, looking at patients that were treated orally or IV after the publication of POET. The primary outcome was a composite of multiple components, and it didn't quite achieve statistical superiority of oral therapy. The p-value was 0.051. But geez, oral therapy sure looked better. If you look at just the all-cause mortality component to the endpoint, there was significantly less death in patients treated orally. The fifth study is this. This is the largest endocarditis study I've ever seen, 5,000 patients. However, this is administrative data only. It's based on codes, diagnostic codes. So we don't know which patients were treated orally versus IV. What we do know from this study is that before publication of POET versus after publication of POET, the length of hospital stay shortened significantly each subsequent year. So each year after publication of POET, hospital length of stay decreased year after year, presumably because more patients were being treated orally, and yet there was no increase in mortality, and there was actually a decrease in relapse. Finally, the study from France just came out last year. 200 patients treated IV, 100 treated orally, mostly left-sided, lots of prosthetic valves, lots of staff. Once again, patients treated orally had statistically significantly better outcomes. And importantly in this study, they asked the question amongst the cohort treated orally, were there differences in patients who did or did not meet the POET eligibility criteria? In other words, they asked, if you expanded the population beyond the very strict enrollment criteria from the POET trial, did patients do worse? And the answer is they did not. Again, suggesting and validating that even if a randomized controlled trial has used very strict enrollment criteria, there are real-world observational data that suggest the same outcomes are achieved, even if you're not that strict with enrollment. So that brings us now to the randomized controlled trials, of which there are 4. We've already shown you the first one, the COPAT trial from West Virginia. We showed that in the osteomyelitis section. So we'll go to the 3 remaining randomized controlled trials and a quasi-experimental study from France. People sometimes forget the earliest randomized controlled trial, which is now 35 years old, believe it or not, for endocarditis. This was all strep. There was no staph. It was viridans or bovis strep. Half were given oral amoxicillin, and everyone was cured. There were no treatment failures. The second randomized controlled trial was all staph, no strep. This is 100% Staph aureus in people who were injecting drugs. This is Johns Hopkins randomized controlled trial. Now, one of the important things about this trial, the patients were randomized to oral therapy or IV in the emergency department. There was no IV lead-in. Patients who got oral therapy had 0 IV lead-in. They were immediately randomized to oral or IV in the emergency department. They used an oral regimen most of us would not trust today because Cipro is not a good staph drug, but they didn't have advanced generation fluoroquinolones, so they combined it with rifampin. There was no difference in clinical or microbiological cure and no difference in survival between the 2 groups, but there was a massive difference in adverse events. Remember that the IV agents we use to treat staph cause lots of toxicities. Allergic interstitial nephritis, hepatotoxicity, the line itself. So once again, equally effective and safer oral in staph endocarditis. The quasi-experimental study is worth mentioning. I wish it was a randomized controlled trial, but it wasn't. It was a pre-post. The important thing about it is it was large. So 171 patients treated orally compared to 170 previously treated IV. And it was all Staph aureus. No strep, 100% Staph aureus here. Mostly left-sided endocarditis, lots of prosthetic valves and devices, and there was a fair amount of MRSA. They used a weird IV regimen. So what they did is in 2012, January of 2012, this hospital put into place a new treatment protocol for Staph aureus endocarditis. You would get 1 week of IV Bactrim plus clindamycin, a very strange IV regimen. And after 1 week, you would switch to high-dose oral Bactrim for 5 more weeks. They treated patients like that for 7 years. And in 2019, they looked at 171 consecutive patients treated with this regimen. And they compared them to 170 patients historically treated during the prior decade with standard IV therapy. Patients given this oral regimen had statistically significantly less death. Notice the magnitude of the difference in death here. It's 11% absolute reduction in death. That number is going to come up again in a minute when we talk about the POET study. Obviously, the largest and most important of the 4 randomized controlled trials for endocarditis was POET from Denmark. 400 patients randomized, mostly left-sided disease, and again, lots of prosthetic valves and devices. In the initial publication, with about 6 months average follow-up, there was no significant difference in outcomes between patients treated orally or intravenously. Oral worked. It established that oral worked. Notice numerically, treatment failure and death rates were lower in the oral arm, but it wasn't significantly different. However, the same investigators subsequently published 3.5 and then 5-year follow-up data of the same patients. By 3.5 years of follow-up, patients who had been randomized 3.5 years earlier to oral therapy had statistically significantly less death. And notice the magnitude of the difference in death, 11%. The same as was seen in the French quasi-experimental study. Now, one of the fascinating things about this outcome, which is very hard to understand, is the divergence of the mortality curves. Here's your mortality curve for IV and oral. That divergence began during the first 6 weeks of therapy, but it got bigger over time. 2, 3, and 4 years after the infection was treated, those curves were still diverging. What could explain that? Why would you still have a higher risk of death 2, 3, or 4 years after your infection was treated? I don't know for sure, but I think the most likely hypothesis is you avoided harm. You didn't develop a deep vein thrombosis that required long-term anticoagulation, which was going to harm you for years. You didn't develop central venous stenosis. You didn't develop a complication in the hospital that required other interventions to be done to you. So it's probably harm avoidance that is causing this continued divergence of benefit of oral therapy over time. So for endocarditis, we have more than 20 observational studies, a quasi-experimental study, and 4 randomized controlled trials showing that oral therapy works. In the largest of these studies, not only was oral therapy not worse than IV, it was superior to IV. And in not one of these studies was IV superior. Here is a summary table of your 4 randomized controlled trials. Your quasi-experimental study is here in italics. Here's your weighted average success rate of just the randomized controlled trials without the quasi-experimental study. If you add in the quasi-experimental study, it doesn't really change the result. It really is the same thing either way. And here's your random effects meta-analysis forest plot. I can conclude statistical superiority of oral therapy for endocarditis. So, across these 3 diseases, we have 24 randomized controlled trials showing that oral therapy is safe and effective, and we have not one published contrary controlled study. It's worth also remembering we only talked about these 3 diseases. Oral versus IV in randomized controlled trials has been studied in all of these diseases, 59 trials that I found. Not a single one has ever shown IV is superior. Across any of these diseases, including bubonic freaking plague. They studied bubonic plague, people, and oral therapy worked. Cryptomeningitis, oral therapy worked. What is this madness people have about IV? Okay, we're in the home stretch here. Let me go through a couple of the frequently asked questions, and then I'll stop and turn things over to Dr. Jung. The first question I usually get is, look, are you off your psych meds again? And look, it's a fair question. I get it. It's fair. I'm off my psych meds. It's true. But it's okay. I'm taking voltage now, and so it's working. They keep escalating the amps. I'm doing better. It's fine. This is the least crazy thing I've ever said. So yes, I'm crazy. I get that. But this idea is not crazy. Are you saying you can just use any oral agent you want? No. I don't know why people think I'm saying that. I certainly wouldn't use sulfanilamide to treat endocarditis. No. Use a bioavailable agent that has published efficacy data. Lord knows there's enough options out there that meet those criteria. But the trials have flaws. Okay, folks, seriously, folks, we went through this. You can't complain about the trial flaws of 24 trials that show the same thing when you have none showing the opposite conclusion. Furthermore, I'm going to raise something that I call the burden of proof paradox. It's very clear that IV therapy is less safe. So based on where we are today, with 24 published studies showing that oral therapy is safer and effective, if you're an IV pusher, if you're insisting on IV therapy, the burden of proof is now on you to establish the superiority of IV therapy. The burden of proof is no longer on oral therapy. But guidelines, I have to give IV because the guideline, guys, I'm done with the guidelines. I'm done. If people think that their opinions should be turned into stone tablets descended from the heavens because they said so, I'm done. Okay? This is why we created Wiki Guidelines. The Wiki Guidelines charter prohibits making a recommendation unless you have randomized controlled trials supporting that recommendation. And we put out an endocarditis and an osteomyelitis guideline. And they both conclude, based on randomized controlled trials, that oral therapy is safe and effective. So if you're worried about guidelines, just cite those and you'll be fine. Finally, I get asked this. How much IV therapy do I have to give before I switch? What's the minimum amount of IV therapy? And the answer is there is no minimum. Okay, you can't draw any such conclusion from these trials. There is a trial of endocarditis and a trial of osteomyelitis in which there were 0 IV lead-in and oral therapy worked. If you look at the ranges of IV in the oral arms, there's no relationship between prolonging IV therapy and having better outcomes. So instead of making up arbitrary IV durations, use clinical criteria to switch. You can switch when all 5 of these criteria are met. The patient should be hemodynamically stable. If they're hypotensive, they may well not absorb anything given orally. Why would you give them oral therapy? If the patient needs a source control procedure, you're going to need to make them NPO. So they can't take any oral meds before the procedure. Why would you give them oral medications and then make them NPO? Get your source control procedure done first. There needs to be a published regimen with published efficacy available to cover the bacteria you're worried about. The gut needs to be working and the patient shouldn't be throwing up. And there should be no economic or social reason to prefer IV therapy. In the United States, sadly, sometimes I can get somebody who's homeless housing if I put them on IV therapy. The insurance will pay for a skilled nursing facility. For that patient, that might be a huge win. So the point is that when all 5 of these conditions are met, that's when you switch to oral. If that's on day 1, do it on day 1. If it's on day 12, do it on day 12. With that, I will stop and we can open the floor up to discussion.
Thanks very much, Brett, for a really impressive talk. And I think many questions have been raised and answered at the same time already. So we'll now switch to Norma Jung, maybe for some comments and some specific viewpoints, as she's also very much into research on intravascular infections, but also bone infections and osteomyelitis. So we're much looking forward to that, to open the room for discussion and commenting. Thank you.
So Brett, very, very nice talk. Thanks a lot. So you really emphasize what's so important in infectious diseases, and I just read also your comments you didn't include for this talk about inflammation parameter. We just having a nice talk about having inflammation parameters. It's everyday practice, I guess, in your clinic as well, that you treat a CRP and not the patient. So very nice. I just asked you, what are you doing in your hospital? Just being very practical to implement that the oralization is done very early. So like, do you have like algorithm in the electronic file or something? And what I often think, what are the barriers that people don't trust the data? Why don't they? I mean, you said like it's also for economic reason, because, you know, if it's not IV, sometimes it's not paid. Sometimes it's the same problem in Germany, and we don't have we build this up at the moment in Germany, a better outpatient service, but it's still it has to be built up. So it's also for social factors. So do you know, do you plan like a survey, just so we know what's the problem that people still don't trust the data? Just to begin.
I think that there's actually a lot of literature on this generally for physicians. It's been published repeatedly that it takes doctors 15 to 20 years to evolve their practice from the time practice-changing studies are published. So I think the biggest barrier by far is simply psychological. Now, you know, there are economic barriers. You're absolutely right. I'm not expecting doctors to fix that, right? If there's an economic reason to prefer IV, use IV. Like you know, there's a social reason why IV would be better, do the IV. That's still going to be the minority of patients. We need to get people to the point where they're comfortable with this concept. And people often ask me, how do you do that? And I would very much like to be able to tase doctors, just go around with a taser and just start tasing people. But my medical staff has not granted me tasing privileges, so I'm not able to tase. So what I'm left with is nagging. Okay. So what I do is I refer people to the movie Finding Nemo. If you remember Dory from Finding Nemo.
Yes.
Just keep swimming. Just keep swimming. We're going to keep talking about this over and over and over until we wear people out.
So you also need psychological support to to keep swimming all the time, all the publications. That what I really you must know also the very nice comment of Rita Rabin in JAMA in 2023. What you just said, it takes 17 years for evidence to change a practice. So this is really 17 years. Can you imagine? It's a very long time. As what we say often, to change clinical practice, sometimes we wait until we change persons as well. I have to admit. I don't know if you'd say the same experience. Sometimes it happens like this. But what we were wondered if it's also good to have a psychologist in the antibiotic stewardship team, because this is what we need to know. What's the fear of the doctors not to comment. Just a specific question. Looking at the POET trial, when you look at the regimens they used for oral therapy, I just wonder how they choose these complex regimens in always two antibiotics. So sometimes it's quite difficult to transfer this in clinical practice. How do you deal with these questions?
It's a great question. I didn't include this slide in the talk today, but I do have a slide. I'm a sci-fi nerd. So I don't know if anybody are Star Trek fans here, or you Trekkies, but I'm a Star Trek fan. So in Star Trek 6, which was the best of the original movies, okay, that's not even a debate for me. 6 is the best. I don't accept any other answer. Mr. Spock says, logic is the beginning of wisdom, not the end. I have now extrapolated that to POET. POET is the beginning of wisdom, not the end. It is the most important of the 4 randomized controlled trials for endocarditis, but it is only one of 4, and there is a quasi-experimental study, and there are multiple observational studies. So I don't think you have to do everything exactly the way POET did it. We have other studies that show monotherapy regimens work as well. When do I use dual therapy regimens? When I'm nervous. So for example, we don't have that much enterococcus data. I tend to get a little nervous about enterococcus. I tend to use dual therapy for that. Not that I'm saying you need to, I just am nervous, right? But I'm very comfortable with, for staph and strep, using monotherapy. We have very good single agents that treat those organisms.
Okay. And then just another question I always have in daily practice, like as you also said, when looking at the length of treatment, often far too long, and always a duplicate of 5 or 7 days. It's always I'm always advising people now when I do infectious disease consultation, I do 8 days or 4 days, so to be different, so to think again. So if it's reasonable. So especially for brain abscess, I think it's really difficult because they have not a lot of symptoms, and everybody's saying you need an MRI to check but we know from vertebral osteomyelitis you don't use an MRI if you have clinical success. So I think, do you have like a new idea? This is often what we are saying. We need a good clinical view that we have a treatment success, but often when we're looking in details, it's quite difficult to say there's a success.
I'm happy to come back in the future and do the shorter is better talk.
Yeah. Okay. Sorry.
Well, no, it's fair. The challenge with brain abscess, in contrast to osteomyelitis, is that we don't have a randomized controlled trial for brain abscesses for duration of therapy. So I'm very comfortable with osteomyelitis, as you say. We actually have multiple randomized controlled trials for the treatment duration for osteomyelitis. I will tell you that when I was in training 25 years ago, we actually did get MRIs at end of therapy because we were chicken and we didn't have trials. And you know what they all showed? They all showed continued marrow edema, could be infection or bone remodeling. So we would treat for another 6 weeks.
Yes.
And then we get another MRI. And then and I'm like, why are we doing this? And now we know we never needed to do that. You're absolutely right. But what we don't have is a duration of therapy trial for brain abscess. That's the frustrating thing.
Okay. So I think there are a lot of other questions from the other person here now. So
Yes, thank you. So I might just add one, which you partly replied to already with regard to the POET trial and different regimens. I was also wondering, I mean, there's also this sub-study on the probability of target attainments for different drug regimens. And I mean, this is, I think, also why something we, at least in Europe, easily confuse clinical colleagues with. That, for example, in the past for Staph aureus, we always told them, well, you can do, for example, your cloxacillin or oxacillin or flucloxacillin, however it's called in the different countries, for your IV treatment, but you shouldn't do then oralization of the same drug. Whereas in parts of the POET trial, such things are also used. And if you then have a look at the probability of target attainment, I think it's 10% or so. So I wonder a little bit how it still worked so well overall, if some parts of the regimen of the orally chosen drugs were possibly, from a pharmacological point of view, not the ideal ones.
I think, Soren, the answer is that there you needed a second drug. So if the cloxacillin orally was only a 10% target attainment, but the rifampin was 95%, it was the rifampin doing the heavy lifting, right? I think, that's where you start saying, I don't have a lot of confidence in this agent. I'm going to add a second agent just in case. But for staph, we have linezolid, and we have trimethoprim sulfa, and fluoroquinolones plus rifampin, which really do have very good target attainment and very good bioavailability. So I really do think there's nothing wrong with using two if you're nervous, but if we have really good bioavailability and target attainment data, I'm perfectly comfortable with one.
All right, thank you. A second follow-up question. You also mentioned in the FAQ, well, what is the minimum duration of IV? Now, I got that there's no minimum IV duration. However, from a psychological or pragmatic point of view, do you then sometimes tell people, for example, you have a patient with bacteremia, then you start on a specific treatment, let's say ceftriaxone, and then you get your blood culture back the same day or the next day positive for E. coli. So do you or does it help to convince people to tell them, well, now you had your 24-hour ceftriaxone, now you can put the patient on quinolone and then treat as an outpatient or as well? Because I mean, if people are not too septic, I think the second question immediately arising after it switched to oral treatment, whether you can't treat them on an outpatient basis, and how do you manage these bacteremia patients then? Would you see them regularly in a specific outpatient center? Because I think there's other rising consequences from that as well, from the early organization.
So I think that as long as the patient has some evidence that they've improved, so it's not an ESBL that I've missed, I'm perfectly happy discharging on day one on oral therapy. Now, how the type of follow-up is going to depend on the scenario. If I don't know the susceptibility of the organism, we have a program where we enroll them in something called Safer at Home. We send them home and we do virtual visits daily until we know that they're on the right drug. Once I know the susceptibilities, as long as they're better, we disenroll them from Safer at Home and they just finish their course of therapy. But if we don't know, we're guessing that it's quinolone susceptible, they'll be enrolled in Safer at Home and they'll get a call tomorrow to double check the susceptibilities and if necessary, change their drug.
Right. So maybe another follow-up and also last question from my side would then relate to the susceptibility profile. So I mean, especially in the case of gram negatives, we do see the rise of multi-drug resistance, carbapenem resistance, etc. So we might end up with cases in which no oral treatment is possible. So from your perspective, if you think through all the different ID entities, which symptom or which disease is the one where you would desire to have either a new oral agent or a good, convincing trial that oral treatment is possible?
Clearly, to your point, where we need a new oral agent is the gram negatives, because we're left with the fluoroquinolones, Bactrim, and frankly, increasingly we're using fosfomycin. because most of our gram negatives do remain susceptible to fosfomycin because we just don't use it that much. But so that's where we need a new oral agent. There's no question. To be honest, we don't have that much carbapenem resistance in Los Angeles, thankfully. Really, it's ESBLs that so they got ceftriaxone, which wasn't even effective, and we didn't know it because it was an ESBL. Our protocol is when we're going to send somebody home like that, is we give them a single dose of aminoglycoside, because most of the ESBLs do remain aminoglycoside susceptible. And that way I have some active agent on board for the next 24 to 48 hours while they're being switched to orals.
I have one single question, or actually commentary, or somewhere between, because Caroline and me, we are both working in kidney medicine and dialysis patients, and we always have this issue that people come to us thrice a week for dialysis, and we often try to find an antibiotic treatment that may be given IV only thrice a week, which is very difficult. And I used to ask Sören time and again, well, is there something to give? So this seems very practical for nephrologists to switch more easily to oral drugs. Would you see, and I have to ask you this as a nephrologist, would you see any special topic here in people with advanced kidney disease in dialysis patients? Or would you say, well, as far as we know, we can actually transfer the finding from the general population to our dialysis patients?
Well, I think you definitely can. You just have to dose adjust based on the GFR. Interestingly, in the United States, usually dialysis is 3 times per week. And so they could get cefazolin or ceftazidime or something with each dialysis, and it'll last until the next dialysis. So I do find we use more IV actually in the dialysis population. Now, if it was twice a week, that would be harder because it won't last that long. But for 3 times per week, you can probably bridge to the next dialysis with an IV drug.
So it's 3 times a week, so thrice a week in Germany also.
Oh,
Huh? Yeah,
right.
sorry.
Got it. Yes. Okay. Yes. So we do use IV not uncommonly in that scenario, just because it's easier than asking the patient to remember to take oral. The dialysis center will just infuse the drug with their dialysis. But there may be times where oral is preferred, and I have no problem giving oral in those patients.
So many thanks to you, Dr. Jung and Dr. Spellberg. It was a pleasure to have you here as our guests. And I'm delighted to announce that we look forward to a new episode next year on the topic of the duration of antibiotic treatment. So I hope we will see you here again soon.
Look forward to that. Very good.
Thanks a lot. And I can also advise the choosing wisely climate change advices, which also show that IV is much more harm than oral treatment. Just a last comment.